Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode 211 of the Better Health Guy blogcast series. Today's guest is Dr. Ritchie Shoemaker, and the topic of the show is Actinobacteria and Endotoxins in CIRS. Dr. Ritchie Shoemaker is a recognized leader in patient care, research, and an education pioneer in the field of biotoxin-related illness. While illness acquired following exposure to the interior environment of water-damaged buildings comprises the bulk of Dr. Shoemaker's daily practice, other illnesses caused by exposure to biologically produced toxins are quite similar in their final common pathway. What this means is that while the illness might begin acutely with exposure to fungi, spirochetes, apicomplexans, dinoflagellates, and cyanobacteria, for example, in its chronic form, each of these illnesses has similar symptoms, lab findings, and visual contrast sensitivity findings. Taken together, the inflammatory illness from each of these diverse sources is known as Chronic Inflammatory Response Syndrome, or CIRS. And now my interview with Dr. Ritchie Shoemaker. Dr. Shoemaker and I had an enlightening conversation on Genie in episode 205 of the podcast, so I encourage you to check out that episode. Today, we're going to talk about Actinobacteria and Endotoxins in CIRS, or Chronic Inflammatory Response Syndrome. I've been very much looking forward to this conversation, to learning more about these emerging topics, and thank you again for being here, Dr. Shoemaker.
Well, it's my pleasure. We had such a good interaction the last time. I'm counting on number 2.
I hope so. First, I wanted to just do some very rapid fire questions, really related to our last discussion, things that came to mind or questions that people asked that maybe would help clarify things for them. We'll do those and then we'll get into the deeper conversation. So we said in that last conversation that mold and mycotoxins were only 7% of CIRS causation based on Genie findings. And so that led me to starting to wonder whether that means that only 7% of people with CIRS have mold and mycotoxins as a component of what's driving their condition, or is it more common that there are multiple triggers or contributors that would include mold and mycotoxins? Could be actinobacteria, could be endotoxins, but could those same people also have mold and mycotoxins? Is CIRS single causation or multi-causal?
Over the last 25 years, one of the most difficult questions has been, how do we prove causation? Now, most of the studies that were done back in the early 2000s were association studies. Some of the good prospective exposure studies or studies that would be looking to prove causation were done in animals, and Dr. Rand's group in Nova Scotia was doing a lot of stuff with installation of toxins, installation of whole cells for fungi. And you can't use one item alone to conclude causation. Now, Genie has come along, has rendered this question moot, because now we have specific causation for actinos. That doesn't mean that people with specific causation for mold don't have exposure to actinos as well, to your question. But if we're looking at exposure, we can't show causation without a genomic or immunologic event preceding this. Now, if we have TGF-beta1 going up after exposure to water damaged building, what does that say caused the exposure? Well, we can't say mold, we can't say actinos, we can't say beta-glucans necessarily, but we can say there's inflammation. So Inflammation is one element we need to consider. But then the second one is, can we use Gini to show specific and precise causation? And that was one of the quotes from Scott McMahon in one of the early papers of the series, specific and precise. Yes, we can. We know that if we have elements of MAP kinases and TGFBR1, 2, or 3, that person has got specific causation for actinos. If we have specific causation for fungi, there will be specific causation of apoptosis with 2 fungal markers out of 3. And then a second layer would be MAP kinases, but at a much higher level, at a 3 or 4. So those 2 things are pretty much clear. With endotoxins, we're looking at CD14, TOL2, and TOL4. Now, TOL2 is got a lot of interest for me right now with the causation of neurologic injury and dementing illness and all that. When we talk about skin carriage of particularly P. acnes and Corynebacterium tuberculostericum, those organisms are showing both specific causation for peripheral functioning abnormalities, but also showing central nervous system injury as well. So TOL2 has got a twofold factor behind it. I haven't published this yet, but it'll be soon. But the issue is that when we get into talking about skin and actinos, you need to know that if TOL2 is present, you've got microglial cells and increased inflammation in the central nervous system. It's a long way of saying that the level of precision that we now have lets us say causation. If we look at association, then all bets are off. TGF-beta1 could mean fungi, could not mean that it has to be fungi. But it's kind of hairy. And the way your question was written, I want to make sure that the 7% for fungi, 28% for endos, and 42% for actinos was specific causation. So inflammation, meeting case definition of CIRS, that's one. Number 2 is that we've got transcriptomic identifiers that are unique to this grouping of organisms.
So the way I interpret that is to establish specific causation, we need that Gini transcriptomics data. And from a Gini test, someone could have a single cause or multiple causes that are identified.
Exactly.
Wondered if we have any new insights on HLA types that might be more susceptible to our conversation today around actinobacteria. Endotoxins, also interesting. If we look at HLA-DR for mold, we know that we can not have an HLA-DR for mycotoxins because that's not a protein. So does that mean we will likely never have an HLA-DR for endotoxin susceptibility? Or might we uncover an HLA that is more bacterial susceptibility that could then be more of an indirect surrogate marker for endotoxins, similar to what we do today with mold and mycotoxins?
The need for an HLA surrogate for endotoxins is huge, because we have, as in the brief little talk on endotoxins, you'll see that the structure of the endotoxins determines its function. And this could be from a bacteria that's a gram-negative rod like E. coli, but it also could be from Klebsiella. It also could be from a third unknown organism. So we don't have specificity for the endotoxins that we're looking for. And looking back on the HLA work from 2003, when that was published, we didn't have consideration of actinos or endos. So we never did the same collection of data with environmental sampling for that. But having said all that, there are a couple studies, including one of the COVID studies, that did look at HLA for actinos and endos. And these people who had endos predominantly were 4353. 36%. Or 11352B, another very common one found in actinos and endos, was 11352B, and that was 24%. So we're not getting specific endotoxins. We are getting group exposure to a HLA process.
For many years with HLA-DR, my understanding was that that could only properly be done from a blood sample. More recently, I've seen Life Extension Foundation having a saliva-based HLA-DR test that goes to Kashi Clinical Laboratories. Have you had any experience with salivary HLA-DR, and is that accurate in your opinion?
LabCorp put on a HLA for saliva testing for us about 2005. The problem we ran into is that the PCR assay that LabCorp uses also has an SSOP model to it. So that if you look at all the numbers written at DRB104, that's going to be telling you this 4353. But the other numbers are saying which is one of the 12 subtypes of 4353. So in that one has an 0404 and 0405 and 05, all these other ones are secondary numbers. So what we looked at with saliva testing is lack of reliability for these secondary markers. Now, I've heard that there is a saliva test that has passed some review. I've not read anything that has been published. Has Kashi published, and I just haven't seen it? There's no reason that the technology for PCR couldn't be done in saliva. And there's no reason a priori to say that I wouldn't do this, but I would only do that in comparison to established nomenclature and established methods.
You mentioned in our last conversation that we need to be more concerned about MARCoNS if they are making polycyclic ethers. How do we determine or know if someone's MARCoNS are making polycyclic ethers? Is that something we glean from Gini? Is there some other assessment? And what percentage of people with MARCoNS would you suspect are creating these more concerning polycyclic ethers?
What we did, being Joe Musto and in my samples some years ago, would be to take a 96 well panel. MARCoNS has been grown up in tissue culture with the supernatant of liquid over top of the bacteria is aspirated, put into a well, and then a lab that does liquid chromatography can identify toxins or molecules that are in the supernatant. The problem is that when we had each of 3 separate toxicology labs that did this, the polycyclic ether toxins were recognized as being present, but not which one. They were unique. There was no library in the world's literature back when Joe and I were doing this that would tell us what polycyclic ether it was. It could have been monensin, it could have been a nigericin, could have been some other one. But right now, we don't have a number to put on it. Now, having said that, we can look obliquely at mitoribosomes. There are 2, there's large and small, as one of the Gini tests. If mitoribosomes are less than 0.91, that organism is going to be making a polycyclic ether. If it's 0.92 and above, statistically, it's not going to be making a PCE. So when I see people going through all kinds of headache and heartache and ripping their hair out over MARCoNS that's not being eradicated, just simply get a mitoribosome large and small. And if those are normal, you can forget about polycyclic ether toxins.
That is amazing information. Definitely helps because I, to your point, have seen people that have tried to clear MARCoNS for months or years. Obviously, that is a challenging process. And if it's not necessary, then that is something that we can focus that energy on other aspects of our healing. In our last talk, you were very excited, and I am as well, about the new testing that's coming from EnviroBiomics. I believe now they've kind of spun that off into human biomics. Hopefully that will standardize a lot of CIRS testing. I think it's still being rolled out. So I'm wondering if you've had the opportunity to do any patient sample validation against the reference ranges that we've historically used for CIRS. Do we envision those will stay the same? Do we think it's going to take time with this new testing to compare and come up with new ranges? What are your thoughts on the new testing? And do you envision that the new human biomics testing will remove the current challenges that we have with LabCorp and Quest, constantly changing ranges, methodologies, difficulty getting things to the right lab, like National Jewish for C4A, for example? Are we on the verge of putting all of that behind us?
Well, 3 months ago, Johnny Rossini, who runs EBI, said to me that he would be happy to run all these tests. It would take him a little while. He thought he had everything all done, bought his controls that you can buy it for X number of dollars, and looked at samples. Eric Dorninger has been sending a bunch of samples down to EBI, and he's got everything he needs to come out except for MSH. So I thought, he wants a package with 7 or 10 labs in it, and in one package to be available for $400 or something like that. Not free, but not $4,000, and it'll be available without all the hassles of dry ice and this, that, and the other. And as of last week, he was going to be out this week or next week. So we're from the government, we're here to help you. Is always a funny thing. We're from the lab and we're going to be up and running tomorrow. So, the same way, but it won't be long. That's all I can say. The groundwork has been done.
And when that finally comes out, will that be with MSH, or do you think they're going to proceed without that to bring it to market sooner?
My suggestion was to go without MSH and use what we have. The big controversy has been in normal ranges for MMP9 and MSH. Has been less important. TGF-beta1 has been driving everybody nuts, but that's coming. C4A and C3A have been a real hassle because specimens had to be frozen for Quest, and they can just be shipped overnight in a cool chamber now with Dr. Rossini's methods, and that's all looking good. So the things we needed most, we've got on the way. I was impatient and said, we don't need to wait for MSH. We can just go. And he says, all right, I'll see what I can do.
Wanted to touch briefly, I think the last question before we get into actinobacteria and endotoxins. Now that we have the ability to add specific types of fungus to the ERMI, so Envirobiomics has the ERMI Plus. We can add things like Fusarium, for example. Are there any specific organisms that you think are clinically important to look for in a CIRS patient that are more common triggers, but are not part of the 36 molds that the ERMI generally looks at?
The PCR, qPCR, that Steve Esper brought forward in 2002 and 2006 was a huge step forward, finding where we could do Swiffer testing and not just vacuum testing, was his original model had, was another huge improvement. In 2009, we came up with HERTS-Me2, and that was a bigger advance because it really looked at risk of re-exposure. People who have been sick before, and there was a significant overdiagnosis of ERMI, and HERTS-Me2 was very precise, and that's true to this day. But the issue is that now we've got next generation sequencing. We've got the most accurate fungal identification that we can look for. We don't need to do qPCR, even though it's less expensive, when we've got next gen sequencing, which is one of the things it's going to be going forward. That'll be more of a factor as we go down the road, because we've got next generation sequencing from bacteria, next generation sequencing from fungi, and now hopefully they'll be able to do cyanobacteria as well. That number is out, but just hasn't been, people hadn't crunched the numbers to say what it's going to be run. My concern with Fusarium, for example, is that Fusarium has so many species and subspecies. They're not the same. For example, Fusarium oxysporum is being used in Colombia to kill the cocoa plants, and that's now the organisms there are resistant to Fusarium oxysporum effect. In Florida, where the nurseries were, where Benamil was used, there's another different Fusarium oxysporum. This one is subspecies select, and it is a marker with Pseudomonas fluorescens to look in soil types because Fusarium oxysporum makes cyanide. That's how it kills its competitors. But now some of the other organisms, Fusarium is sitting there making cyanide, killing things. Along comes Pseudomonas fluorescens. Pseudomonas can be programmed to eat everything, whether it's oil slicks or toxic chemicals, slicks from the train crash or growing in a nursery plant in Florida. You can tell if by a soil biopsy if you got Fusarium oxysporum select because you'll have cyanide that's being metabolized as a carbon source. So I'm not sure where the research is going, but I know back when Fusarium was first proposed to be part of ERMI, there were too many subspecies that could not be controlled for.
So it sounds like we, over time, will move from MSQ, PCR, or ERMI to next generation sequencing. Is that fungal next generation sequencing something that's currently available through Envirobiomics, or is that in the future?
I believe it's available now.
So before we get into some of my questions around actinobacteria and endotoxins, I know you wanted to give us a little bit of a history and background of how this emerged to kind of set the stage. I believe we'll put some slides in the show notes for people to look at, since I know many people are not watching the video version. But if you want to touch on history and background of actinobacteria, and then we'll get into some additional questions.
Some of the acronyms that I use and Scott has read are ones that are still not part into the parlance of everyday CIRS practice. So when we talk about DI, that's dominance index, PI is prevalence index. This is looking at the difference between soil-based actinos and human habitat-based actinos. Scott had a couple questions about those, so be paying attention. They still are of tremendous use sorting out the different kinds of actinos we have. We mentioned briefly some of the specific causation, MAP kinases or MAPKs. There's 6 of different ones. TGF-BR, that's TGF beta receptor. There's 1, 2, and 3. These are important for causation for actinos. And again, folks may not be talking about receptors as commonly as we do in the actino world. The state of the art about actinos, I'm just going to read from MRA 2021, Volume 9, Number 3. It's a paper that our group published, Shoemaker, Heyman, Lark, Neal, van der Weysen, and McMahon. Identification of immune reactivity specific to actinobacteria are revolutionizing detection and quantitation of newly recognized pathogenic actinos. Approach to genomic basis of diagnosis and treatment of disease is manifested by differential gene activation. And 3, quantification of exposure and confirmation of risk has led to advances in metabolic inflammatory issues based on MAP kinase activation and TGF-BR signaling. I'm reading this to you because I want you to know that this is what the actino world sounds like when you talk to someone who's doing this on a daily basis. Now, remember, when we talk about water damaged buildings, are basically no two are really the same, because there'll be different location, different duration, different exposure, identification models using different salinity, different temperature, different timing, intermittent versus chronic, sudden cold or sudden warm with a flood, hurricane wind and rain, trauma or not, rainfall with trauma versus storm surge alone, 8 foot deep versus 2 foot deep, interior events that are non-catastrophic. And basically, all these different factors need to be thought about when you say water damaged building. It's not just water intrusion through the ceiling and the roof. It can be otherwise present. Now, the basic concept that separates actinos from fungi and bacteria is activity of water, or AW. The measure of water vapor as an ecological variable has been around for years. The available water in the air as a percent of absolute will give us the partial vapor pressure of water in a solution divided by the standard state partial vapor pressure. It's a physics number, but it's something that you need to be aware of. If you find activity of water of 0.9 or greater, be thinking of that's where endotoxins are going to be growing. You find some stachybotrys and some Etomium, that's where they'll be growing is in the fungal world. But then if we look at actinos, they can grow in any AW, whether it's water saturated at 0.9 or dry at 0.55, where you find Wallemia. So it's kind of tough to talk about ecology of actinos without knowing AW. Basically, we want to know how wet is the ecosystem. Now, one thing that's confusing to me still is actinos can make surfactants and emulsifiers that will affect functional AW. I don't know how to measure actinos and surfactants and emulsifiers, but it'll take a water-saturated environment and make it a dry environment quickly, make a dry environment into a wet environment also quickly. So what we're trying to do is to make water bioavailable to competition. It's similar to the nose where you've got mucopolysaccharides. I know we got some questions on actinos in the nose. The question is, what is the surrogate AW in the nose, and is it reduced by mucopolysaccharides? The answer is yes. So the role in secretions to offend against condensals is important in actinos. The other question is, are skin actinos lipophilic? The answer is yes, they are. If there's 2 meters squared of a dry skin surface, there's 25 meters squared in skin and appendages. And what that means is that there is a huge reservoir of retention of actinos in lipid-containing structures that are below the surface of the skin in the skin appendages. So sweat glands and oil glands are where that's working from. But basically, if we ask the question, what are bacteria? Actinobacteria, they're the largest genus of all bacteria. They're lipophilic, hydrophobic, we mentioned lipophilic. They're gram-positive cell walls. They're filamentous, they're hyphae, they're spores, they're biofilm formers. They've got a high ratio of guanine and cytosine and nucleotides. My goodness, how do we separate actinos by their DNA? They've evolved to be high GC. Crazy. They are prodigious manufacturing machines. Actinos have produced known 20,000 different compounds. We're going to say, does actino make a toxin? Well, in the 20,000, I bet they do. Well, actually, we know they do, but how many others in the 20,000 or the polycyclic ether toxins are we yet to discover? Also, actinos will move. They're motile. They'll respond to VOCs. And that motility means you can start out with an actino in your living room when you came home from a soccer game in the wet, but then it didn't take too long before the VOCs in the inner sanctum or the bathroom in the bedroom attracted the new actinos, and they started growing in the different areas. The key issue, and one of Scott's excellent questions for today, it has to do with FAB. That means all organisms live in balance with bacteria and fungi if they're actinos. So fungi, actino, and bacteria. We don't want to eradicate all of any of those. We want to keep them in balance. That's a critical issue. If FAB's disrupted, some host will pay with his life. If they're growing inside the body, like cyanobacteria is, that's going to be telling us about skin surface, not soils. That's where the activity indices are so important to look at. Also, actinos make vesicles. Vesicles are not actinos. They're fragments. There's 252 molecules of DNA, RNA, proteins, and iron in vesicles that will be attracting our attention. And the whole idea of actinos in blood, it's not actinos, it's subsets of actinos. It's the little vesicles. What we're going to be looking at later on is mycolic acids as a way to separate some soil organisms that don't make mycolic acids with skin acid, mycolic acids that do. But all I'm trying to get around to is talk about immunoreactivity is where we can make the difference looking at specific causation versus inflammatory reactivity. If you're exposed and have inflammation, does that mean we can tell from the inflammation what it did with the exposure? No. We're going to be trying to go beyond inflammation. In today's discussion, Scott's got some excellent questions that I've already pre-read. But the real issue is that we looked at the 2016 surviving mold consensus paper for indoor environmental professionals. We identified 30 elements found in water damaged building can make people ill and show inflammation. That was done before we had immunoreactivity. Now we can put names and numbers on this one. Some actinos are friendly. They colonize as commensals to protect the gut and the nose, human habitat. They guard mucous membranes and skin. They're all around orifices. Some are going to be there. For example, if you've got a vaginitis in a female, there will be a question of whether it's a fungus or a yeast or an actino or a bacteria. All of those should be in balance. Otherwise, you're going to have itchy problems with that area. The issues we're talking about actinos, they're very commonly are releasing small molecules inhibitors of eukaryotic protein synthesis and nuclear encoder mitochondrial genes or molecular hypometabolism. Those are only measured by Gini. I think that's all I want to say about this section. The two PowerPoints, one will be on actinos, one will be on endos. And thank you so much for including those. It really is important.
Yeah, no, absolutely. And I just learned about 100 new things. So, as I understand, actinobacteria are gram-positive bacteria. We talked about the incidence earlier, 42%. Endotoxin is the outer membrane of gram-negative bacteria, 28% causation in CIRS. I want to talk a little bit about whether it's the actinobacteria that creates the health challenge, or if it is these compounds like mycolic acid. You alluded to the fact that there were many others. Is it the toxins produced by the actinobacteria that are the real problem? We historically have called these biotoxin illnesses. And then is it reasonable to say both for the toxins produced by actinobacteria as well as endotoxins that there is a role for cholestyramine and or Welchol?
We talked about actinos being friendly and commensal. We talked about small molecule toxins affecting the sarsen-ricin loop, not as much as the information was brought forward compared to what we know. But these small molecule inhibitors acting on sarsen-ricin loop are metabolic poisons. They're creating deficiencies of messenger RNA, and as they're also impacting on transcription of mitochondrial genes. So this is a thing that the actinos can do, but they do other things as well. Valinomycin and VDAC, the translocases and voltage-dependent anion channel. One of my concerns about valinomycin is that it'll block the voltage-dependent anion channel, and that is fomented by curcumin, by turmeric. And a lot of people are using curcumin. And when you take curcumin, which is anti-inflammatory, you will block VDAC, you'll block mitochondrial uptake of compounds made by actinos, and you'll create danger in molecular hypometabolism. So it's one of the things that I hear every day. Well, how about curcumin? Well, that's something pretty good. Well, if you look more carefully, there's a literature. Kathy Head from Hopkins has published some extensive work on VDAC and valinomycin. In the mitochondria, in complex 1 and complex 3, there are two actino compounds. One is pyrosidin A, the other is oligomycin, that disrupts the electron transport chain. So this is a problem that'll create chronic fatiguing illness, but it's not from a toxin, but it's treated by an actino molecule that's bound by cholestyramine or Welchol. I don't have any data on charcoal. You were saying that it's good for endos. I need to know more because it's not in my lexicon. But the whole answer to the question is that in the 20,000 kinds of molecules that actinos make, we've got metabolic poisons, we've got metabolic disruptors, and we've got biotoxins like polycyclic ethers. And I'm sorry for the long explanation. But it's very important that you have a working understanding of just how complex and how important the actinos are.
So it sounds then like there is a role for cholestyramine and Welchol in both actinobacteria caused CIRS as well as in endotoxin driven CIRS.
Yes.
Wondering these days if you would ever run an ERMI or HERTSMI-2 without looking for actinobacteria or endotoxins. And then kind of how do you get from point A to point B? If you're testing someone for the potential of actinobacteria, do you start with their environment and then move into skin, nasal, blood, body testing? Do you start with the body testing and then look to the environment? Or are you driving the testing from the perspective of Jeannie to ascertain the causative factors for that person?
I think this is an extremely important question. The cost of doing sampling for fungi, for endotoxins, for actinos, and beta glucans is $450. And that's on a discount day. Other labs will charge you much more than that. I've seen $1,000 charged by other kinds of labs. But what I try to do is to recommend that we clear the air, so to speak, and say, are we looking at one form, one specific causation, or two or three or four? If we've got specific causation for four, that's going to affect what we do with remediation. If all we have is actinos to worry about, that remediation is very different than what's done with fungi. The remediation for actinos is $50. Remediation for fungi is $50,000 in some common cases. And other times people are vacating homes altogether. But if you recognize that actinos can be removed by iadapt air and endos by iadapt air and fungi by iadapt air and VOCs by iadapt air, that sounds like a good machine to buy. I have three, and Scott, I think you've got a couple of them, or three anyway. Those are items that will pay for themselves every single day. And the safety they provide is such a huge element. When we first put one of the forerunners of iadapt air into my office went from a place that was making people sick, including me, to a place that people could come and look at the stains on the ceiling tiles and say, that used to make us sick, but now it doesn't. Well, we removed the ceiling tiles and replaced them, but we didn't tear the building apart, which is what had been recommended by the people who are running the building mechanics.
So it sounded like what you were suggesting is because the testing is reasonably priced, that we should start with the environmental testing of ERMI plus actinobacteria and endotoxin. Did I understand that correctly?
Yeah, I stopped short of going on the skin. I wanted to make sure you had commented and brought it clear light. The blood testing for vesicles is in its infancy. I cannot recommend it be used as first-line treatment. The nasal cultures, again, if you've got Chronic and tuberculostericum, that's a bad actor in case we've got lactobacilli deficiency in the nose. But that's the only reason I would do that one. So for probiotics, if you're going to use those, the data is not clear on probiotics and eradicating actinos in the nose. It should be there. But actinos are in the gut. We don't want those to be eradicated. So if we start measuring stool for actinos, and I wish people who are looking at microbiome would recognize that actinos have a role in the microbiome of stomachs and large and small intestine. I don't see that nearly as often as bacteria are talked about. But the idea of testing for a skin organism makes a lot of sense if you have found actinos in the home and you tried to iadapt air and you reduced the level of actinos, but you still had a reservoir of actinos, say in the bedroom, in the bathroom, or the closet. I would be then looking to see if there is a reservoir of actinos deep to skin in the skin appendages. So what we do is to take isopropyl alcohol and rub it on the back of the little bottom part of the lobe of the ear. That'll dry out secretions that might be there from earlier in the day. and then within seconds, you'll see some extrusion of fluid where you write for the rubbing alcohol, and that is where we would then sample for the actinos. Now, it's mostly P. acnes. If you've got oily skin, you're going to have trouble with P. acnes. If you've got seborrhea, you're going to have trouble. That's the rash that you get in eyebrows and the edge of the hairline and around the nose, and it can be on the skin and the chest as well. But if you've got those, you're going to have a lot of actinos. You don't need to worry about testing for those in the same way. But what will happen is that if you rub with rubbing alcohol a second time, you get a second drop of fluid from sweat glands and oil glands. And this has got more actinos than the first drop did. So if you do this once every single day for a week, you are going to see a blip upwards, rise in what you're getting out of the skin appendage, but that will then fall at the end of a week or so, and then you say you're making progress. Now, the best way, if you don't have seborrhea and you don't have oily skin, to take care of actinos on the skin is to use a soap that will open up the pore and let those little drops of pearly water emerge. I know Eric tried Defense soap. That worked for some, didn't work for very many, and I stopped that. So far, so good for lava. Lava soap is very irritating. It's coarse, it's got pumice in it, but it's almost like taking the head off of a pimple and letting the juice come out onto the skin. So that is a good idea. And then Selsun Blue for shampoo is a good idea. The problem with Selsun Blue is that, are you going to be taking showers 24/7? You take one a week, you want to take two a week. I'd recommend one a day. Take that in the morning if you're going back to work. But I have not seen contamination by walking around outdoors getting actinos in the hair.
So just to summarize then, it sounds like the best practice is to do the environmental testing with ERMI for fungal organisms, adding actinobacteria and endotoxins. And if we're then seeing actinobacteria in the environment, then the skin testing seems to be the go-to. Another piece I just wanted to clarify, because I'm sure people will ask this, is as much as you and I both love the iAdapt Air, I don't think that what you're saying is that you then can avoid doing remediation or source removal. Correct me if I'm wrong.
Early on, some people have successfully eradicated just with skin cleansers and with iAdapt Air. We did a study looking at Genie in a four-step process, did Genie once a month, presented this in 2023. And the program of skin cleansers was one thing, but we also used the, quote, skin cleanser for drywall, and that was with some of the cleansers that can be irritating for those with chemicals. So we stopped using that, but it's on the way to really saying we can affect by cleaning out actinos on drywall. That's once a month together with iAdapt Air.
If there was, however, a mold issue in the home, we're not suggesting that iAdapt Air is the complete solution for an actual water intrusion scenario. We're talking more for the actinobacteria scenario, correct?
Yes.
As you've already indicated, some actinobacteria are potentially healthy. Some of them we tried to get to grow in us. Bifidobacteria, for an example, in our microbiome is classified as an actinobacteria. So we're taking actinobacteria in probiotics. It doesn't sound like the goal is an absence of all actinobacteria in or on the body. How did we determine which actinobacteria are health promoting versus health negating? And are we still primarily concerned about the Propionibacterium acnes and the Corynebacterium tuberculostericum? Or are there other human habitat actinobacteria that you see clinically significant and clinically common?
We haven't mentioned much about Streptomyces as an actino. It makes small molecules that are disruptive to RNA and DNA. But that's one thing that needs to be added to the soil-based organisms because they make these small things. The two species you mentioned, I call it CT, it's easier to say. CT and P. acnes are the main ones we've got to worry about. The NIH has done a lot of work with P. acnes looking at differential activity, the skin activation, production of a toll receptor 2, P. acnes, and it's an evolving field. There's not enough money in it right now, and I have a feeling there'll be less money for NIH coming up than what there had been.
Early on, we separated human habitat and soil habitat, actinobacteria. There was then the creation of this dominance and prevalence index that you talked about. My understanding prior to our conversation today was that we're really not looking at those much anymore, but we're looking more for human habitat actinobacteria over 10,000. We're not concerned about the soil habitat actinobacteria as a causation for CIRS. Wondering if that's all still true. Are we still looking at that 10,000 criteria, whether or not the actinobacteria test is a dust sample or a skin swab or a nasal or blood sample? Or are there nuances about how we determine high levels of actinobacteria? And then maybe extending on my original question, it sounded to me like there may still be some value in dominance and prevalence index.
I still look at dominance index and prevalence index in every one of my people that has an actinodon. It makes a huge difference if we're looking at a low roar, so to speak, of skin organisms inside the home. We don't know about streptomyces just yet, and in small molecule acquisition, that's a big problem. But if I find that there is not a low prevalence index, but a high prevalence index, if the numbers of P. acnes aren't 2 million and CT 3 million, if they're down about 50,000, I'm going to be reassured that I'm not worried about small molecule problems with soil-based organisms. It's difficult because we don't have an assay, a commercial assay we can use. So the PI is staying on the list because of the fear of small molecule toxicity, but the ribotoxin active inhibitory proteins are things we can talk about, but they're not available commercially. So that's just one holdup that we've got. 10,000 is a good number for skin swab, good number for nasopharynx. I'm not sure we know what a good number for blood is, because you can have other elements of vesicles in blood and can't get to 10,000.
And the 10,000, as I understand, is still what's used for the dust sample as well, correct?
Yes.
And are the ranges that Envirobiomics provides for dominance and prevalence index, are those what you are currently using, or are you using a different criteria?
No, we're using the same old one from 2021.
Extending on the human versus soil habitat actino discussion, where in a building are the human habitat actinos? Is it that the building itself is infected, so to speak, by the human from the actinobacteria on the skin? Are the actinobacteria coming from drain pipes and other places where we're not thinking about a water intrusion like a roof leak, for example? And if we do find actinobacteria in a building, in a place where there was a water intrusion or water source, are those more likely to be human habitat or soil habitat?
Well, one thing I like about your interviews is they never give you one question at a time. It's 6 at a time. Well, they're all good questions, and it shows you your thinking process, and I'm delighted to listen to you.
Thank you.
One of the issues about the home is that you will find actinos nearly 100% of the time in wet rooms. So that means a bathroom. In my bachelor days, I would take a shower once or twice a week, and if I had to, I'd come home and leave the beer bottle open on the counter and the wet towel in the bathroom. And so when Cheryl came to visit me and says, "Oh, you need to wash your towels more frequently. Can't you smell these?" And I would hang my tail up to dry. what I did was put a wet towel next to drywall in my bathroom, and actinos could move. And it wasn't too long before that moisture from my hung up towel would be now onto the drywall. So the bathrooms, and then the half baths in the entry foyer and bedrooms, because if you've got a bare groin and a bare armpit, you're a walking culture plate for actinos. So if you put an armpit and you've wiped a towel on it, now you've inoculated actinos onto your towel, and your towel's going to smell. So now I have towels that don't smell, and my bedroom doesn't smell, so all that. And I'm not worried about actinos anymore.
So it sounds then that it could go either direction, that it could come first from the person that maybe had an exposure outside of the home, and that exposure then can become an issue inside the home. Or maybe there was an actino source in the home from, who knows, construction workers, other people in the home, that then the environment becomes the source of the exposure to the person. Am I understanding correctly that that could go either direction?
Yes. Add to that seborrhea. If you see seborrhea, you know you've got a P. acnes trouble.
Is my understanding correct that when we're talking then about actinobacteria, generally speaking, we're not talking about remediation in the classic sense as the solution? You alluded to that earlier. You commented that there was a $50 solution to remediating actinobacteria. Wondering if you could talk to us then a little bit about some of those actinobacteria remediation steps. Are we talking about washing bedding? You touched on towels. I know there's been some debate about the UV light and vacuums on the mattresses. At one point, that was helpful. Maybe then it spread some things. So how should we be thinking about maintaining or reducing actinobacteria in our external environment?
In the study from 2023, which was small, we looked at use of Fantastic, plain grocery store, Walmart, Fantastic, to rinse drywall in the inner sanctum. So that's bedrooms, closets, bathrooms, would be wiped down once a month with Fantastic. You spray it on, wipe it off with a Swiffer cloth and all that. That's not expensive, but boy, that's a lot of elbow grease. That's a lot of time. There's a lot of, but $50,000 is a lot of money too. So what we're finding is that we can eradicate the organisms that are on drywall. If it's actinos, we can make the drywall more acidic. That hurts actinos. And then with the quaternary ammonium compounds that we already know that work, like Fantastic or Windex, for example, we can clear out the carriage on drywall. Now, the problem is you get in the living room, there's the rug, there's the floor, there's the couch, there's the TV, the screen has got dust on it, there's particulates in the air, you've got actino on your TV screen. It gets to be real nonsense. But all these things kind of, it's like your six-tiered question. You know, if you don't get a good answer and you ask another question, you're not going to get a good answer again. And we don't know. We don't have the funding to do this. When I had Krabby, our nonprofit organization, we had raised $2 million for research. And Krabby's no more, and the $2 million is no more. It was all spent. But all these things, costs money. So if you're going to do for yourself, it becomes an anecdotal study. If you clean off your bedroom, in your bathroom, in your closet, and you don't get any actino, it means that you ran 2 actino samples. Well, it means you ran 3 samples because you start off with an iodaptera to begin with. Then you ran 4 samples because one you had a genie with each time. You can run as many samples as you can kind of think of. The key issue to me is to make sure we don't give actinos a reservoir to live.
So when it comes then to the bedroom, which is obviously where we spend a lot of time, is the recommendation then to regularly change and launder bedding? And what are your thoughts on the potential value of some of the UV vacuums that were discussed in the past in the CIRS conversation?
I have not seen any data on UV light. I know that the old UV generators were, and including what was made by Aeroasis, was creating adverse health effects. So UV is not for human consumption. If you've got a fire and you've got to take the smell out of your house, then a UV generator is fine, but let that air out for a day before you come back in after you cleaned out the smell. As far as laundry goes, once a week with regular detergent has been fine. I've not seen anybody yet having to do the laundry once a day. But you don't need to add anything. You don't. One person was washing their bed sheets with cold styrene. They had yellow bed sheets.
Thinking about actinobacteria on the skin, how do we think most people are acquiring it? Is it commensal at lower levels and something that most everyone has to some degree? What differentiates a person that has high levels of actinobacteria versus low levels? Could it be certain people have immune dysregulation that then it becomes more of an issue? How are we coming into contact with the actinobacteria? And what are some of the factors that lead some to harbor high levels versus others having low levels? Or is it maybe that many people have high levels, but they're just not as susceptible to the compounds that are produced by the actinobacteria?
I would recommend that you do a literature search on Yasmin Belkaid, Belkaid. She's done more with P. acnes at NIH than anybody has. Also, I would look on literature search on Rachel Adams. She's done more on actinos in rooms and human carriage of actinos. The data has been published. It's worth half a day reading work of those two esteemed authors. An introduction would be the papers that are on actinocentral and surviving mold that Andy Heyman, David Larkin, and I primarily have done. Scott McMahon's been a co-author. Eric Dorninger's been a co-author. I mean, lots of people have contributed to it. But you're going to need to read and ask questions in the comfort of your own home. I do know that if we look at toll receptor 2 as a discrete factor, it's going to be elevated in people with endotoxins. But it's also going to be elevated when you've got vesicles with P. acnes. So that's where we were saying this is a marker for on Gini for P. acnes. And I was remiss that I didn't mention that this was also something that could be from P. acnes in vesicle carriers. So if someone's got Gini documentation of the immune reactivity to endotoxins, be thinking of actino vesicles as well. But the issue is that low levels of actino, high levels of actino, you don't know until you do the testing. And you'll be doing 4 tests of the skin test before you take care of this initial surge, this blip of high level increase or not. I'm not recommending you take showers with isopropyl alcohol, but if you use something like lava to open up the skin appendages, you'll be getting out over time, month by month, and week by week, you'll be taking care of the body burden without spending a lot of money on diagnostic tests. We've learned that much is that low levels are, if you don't have seborrhea, and all seborrhea people got high levels, every single one of them, and it's Selsun blues for them.
And the reason that as we continue to use something like lava soap, that we have actinos and that actino burden that you talked about coming out of the skin is because they're more lipophilic, and really the large burden of them is really sitting underneath the skin in that fatty tissue, correct?
Correct. And if we look at that fatty tissue, that oil gland, it goes down and it abuts what's called the Reedy Ridge, which is the area in skin where there's blood vessels. And that's where the vesicles go. and how they get out of the sweat gland or oil gland into the blood. Well, they're next door neighbors. There's only one layer of skin, one layer of skin cells that are in the way. But, I just got done saying we don't know enough about vesicles to do much research with it yet. Now I'm telling you to be concerned about vesicles. That's Belkade's work is really telling us that that's where we've got to go.
So to reduce actinobacteria on the skin, early on we talked about coal tar. You mentioned Defense Soap Original Shower Gel. Sounds like lava soap is now potentially the more helpful item. Wondering if people have looked at things like topical silver, topical HOCl, for example, and then wondering what you see when someone has, let's say, a P. acnes of 30,000. They treat with some of these tools, they retest, and now they have hundreds of thousands, or some people even have millions after treating. Could that potentially be that we've reduced some organisms that were in competition with the actinobacteria and thus now they're proliferating more? What comes to your mind when you see someone treating and the actino counts going significantly higher?
We mentioned briefly about the response of increased excretion of lipid materials in sweat glands and oil glands. That's the single biggest cause of numbers going up from skin assays. So if you just stick with it and do another one a week later, you'll probably the numbers will be down because you're depleting the reservoirs of P. acnes in the skin appendages. As far as a genomic basis for who's going to have more P. acnes than another, the dermatologist can tell us more about pitting acne, a notorious source for problems and very expensive medications used. Basically, where C4A comes in is that is contributing to the inflammation that shows up with pitting acne. So pitting acne and P. acnes with toll receptor 2 is a bad combination. So we're not without diagnostic things, but if you find high C4A, high IL-2, or excuse me, toll receptor 2, and then skin levels of P. acnes that are high, you've got a reason now to start cleansing the body differently. I agree with you. You made a point about avoiding antibiotics and maybe using probiotics. Antibiotics are exactly the wrong thing to use. We want to go after habitat and not trying to kill something. Because these organisms, and especially CT, develops antibiotic resistance almost overnight.
One of the things that I've observed in the online communities is people having a subsequent higher result as an indication of failure of the treatment. What I'm hearing you say is that actually could be a very positive sign in that burden of actinobacteria in the fatty tissue is actually now coming out of the body, and maybe that's a very encouraging sign.
I would be encouraged after the third skin test show the number falling down. But it's the same idea has to do with people with dry skin. If you're using keratolytics or scrubs to try to get dry skin off, you're going to get more off early on than you get later on. And it's the mark of a blip upwards followed by a fall that tells you you're making progress.
And you mentioned just a moment ago the third actino test. So are we doing actino testing over a specific period of time? When is someone doing the first, second, third, or fourth actino skin test?
In the 2023 study, we did actino testing once a month and saw this same improvement. So you don't need to spend $150 4 times a month. Just 1 time a month is okay.
And coming back briefly to my earlier question about topical silver or hypochlorous acid, those types of things, it sounds like that's not really addressing the burden so much, that we're not really trying to kill what's on the skin. We're really trying more to liberate what's under the skin.
Yes.
Coming back to the idea of bacteria in the sinuses, we know about MARCoNS. You've alluded to the fact that actinobacteria potentially is found in the sinuses as well. We know we have that test through Envirobiomics. So is there ever a scenario where you would use an antimicrobial in the sinuses? You already suggested that they very quickly develop resistance. So how are we approaching the reduction of actinobacteria in the sinuses where we can't really do some of those things like lava soap, for example? And then do they move from the sinuses into the lungs? Talk to us a little more about actinobacteria and sinuses.
Sinuses is difficult. Getting a culture of the sinus or getting fluid from sinus means endoscopy. It's not the same thing as a nasal swab that you send to Joe Musto for $100 to get Marcons. Those are nasal swabs. That's not giving you a sinus burden at all. So if you've got chronic rhinosinusitis, there's good literature from Germany. Don't be using antibiotics. Use anti-inflammatories. That's where lactobacilli are coming in pretty nicely with probiotics. But the key issue is mucopolysaccharides. What is the AW in the snot that the mucus has? Because if it's dense, thick, water-free mucopolysaccharides, that's the best stuff to clear any third-party organisms in the nose. The battle in the nose is not you and the antibiotics. The battle in the nose is you and the lactobacilli, and you and the other nasal flora that are living and thriving in mucopolysaccharides.
So we're not using BEG spray or silver EDTA spray for actinobacteria.
Correct.
Is there a role for EDTA in addressing the mucopolysaccharides or biofilms that we find in the sinuses? And are you seeing some people that then are attempting to inoculate the sinuses with beneficial organisms?
Lactobacillus works. CT is actually pretty rare. We get about a 10% culture rate, nasal culture. I have not seen anybody do a sinus prep yet for a CT or actinos. Literature is not good. But chronic rhinosinusitis should not be treated with antibiotics. It's a disease of inflammation. Eotaxin is important. TGF-beta1 is driving production of eotaxin. Eotaxin is bringing white blood cells and called eosinophils into the nose, creating the whole hassle that you see with that. So the answer is fix TGF-beta1. That'll fix your chronic rhinosinusitis.
Is there a role for EDTA in providing more accessibility of the lactobacillus to actinobacteria that may be in polysaccharides or in biofilms in the sinuses?
EDTA will eliminate pathogenic organisms over time. It waits until the normal flora grow up better, whatever dropped them down to begin with, so they can compete better and compete against biofilm formation. If you remove biofilm formers with the EDTA, you're good to go.
Are you seeing any commercial preparations or compounded lactobacillus sprays that can be used in the sinuses, or how are people approaching introducing probiotics into the nasal area?
I go to the compounding pharmacy for those to get lactobacilli in spray.
Let's talk a little bit about actinobacteria being found in the blood. You've already mentioned that these really are vesicles. Is a vesicle to a gram-positive bacteria essentially the same as an endotoxin in a gram-negative bacteria, meaning that they are cell wall components or bacterial blebs, that is what is really toxic? You've already mentioned that we don't want to be using antibiotics for actinovesicles found in the blood, which is good information because my understanding was there was potentially a role for antibiotics in addressing actinobacteria. It sounds like that is not the case. So talk to us a little bit about how do we address the scenario where we've gone from the skin into the blood in terms of the identification of these actinovesicles? What do we do about that?
I guess the answer is, where is there a research lab that'll generate an assay for a lipoprotein binding protein, or LBP? If we have a binding protein, we'll be able to take care of endotoxins in the blood itself, and that's a goal. Most people have got plenty of LBP. That's why we don't see too much problem with persistent sepsis from urination or defecation or intimate activity. The combination of red blood cells binding to endothelial cells, linking endotoxin to be then taken up and destroyed has been theoretical, but it's what's happens. Back in medical school, one of the old professors, Eugene Stead, I'm older than he is now, but he was the old guy. He said, if we have bacteria in the bloodstream after a bowel movement, why don't we have sepsis? And he tortured the medical students, including me, because we were looking try to find what research was saying. Well, you don't set off the inflammatory cascade. You don't set off cytokines. You don't do this. You don't do that. The answer was lipoprotein binding protein, and that was you don't hear much about that, but that's. I get asked in just about every lecture, well, how about an endogenous source of lipoprotein? And the answer is lipoprotein binding protein.
So it sounds like if we find actinobacteria vesicles in the blood, that doesn't seem to really change the treatment direction, or is there something specific that would be done if that was positive?
If I can prove that the toll receptor 2 stimulated by P. acnes in vesicles is related to the source of toll receptor 2, that'll be high on my list because that is also going to be knocking down Alzheimer's and Parkinson's. Central nervous system disease of toll receptor 2 turning on activation of inflammation of microglial cells has got a good literature. I'm working on it now. It's going to be answer your question. There'll be a different alternative once I know that I've got something that needs to be treated. And if I've got toll receptor 2 in blood being driven by P. acnes on the skin, I'll be fixing the skin first, hopefully prevent Parkinson's.
Am I understanding correctly that there is not today anything specific that would change if we had a positive actinobacteria vesicle in the blood? We would still be focused on the skin, and that at a later time, there may be some new things that we would use to address the blood vesicles more specifically.
There's a small literature on medications that are toll receptor 2 blockers. That's an interesting idea to add to this. But as we sit here now, the information about what's in the blood, if you can't measure iron in the vesicle, that's a no-no. If you can't measure RNA, can't measure proteins in the vesicle, why bother testing the vesicle? Because those are the 3 players that are really important in vesicles.
So it sounds like there's not significant value today in looking at the actinovesicles in the blood. And even if we didn't have the actinobacteria vesicles in the blood, we could still have many of these toxic metabolites that actinobacteria is producing in the skin and the fatty tissue that are in the blood that type of an assay is not looking for. Is that correct?
Yes. You know what you just did?
What did I do?
You laid it out in black and white for your listening audience, but you laid out what has challenged people for 50 years in dermatology and microbiology and neurology. And you did that in 2 sentences. That was beautiful.
Learning from much more brilliant people like yourself. So when we see actinobacteria in the body, it sounds like even if we find it in the blood, that the original source is coming from the layer under the skin and eventually then potentially getting into the blood. In other words, it's coming from outside and working inside the body over time.
Yes.
Is there a role for next generation sequencing testing like MicroGen DX, or is next-gen sequencing what Envirobiomics is currently using in their actinobacteria assays?
They're already using NGS.
My understanding is that actinobacteria is known to cause dental infections and can commonly be found in the oral microbiome. Do we think that dental infections potentially can be a trigger for CIRS? And are there specific things we might do to reduce oral actinobacteria? Extending on that, if they're in the sinuses, is it not fairly likely that they're in the mouth? And if they're in the sinuses and the mouth, then wouldn't we also expect to find them in the gastrointestinal tract?
We know there can be movement of bacteria from sinus, from nasal secretions into the jaw, into dentin, into the teeth structure itself. So that's why when you do a root canal, you expect to find a markans at the base of the root canal that's identical to the one that's in the nasal secretions. So that's supportive of your hypothesis. Having said that, however, the dentists are more expert in actinobacteria toxins in the oral cavity than anybody else. And the treatment for toxins in the oral cavity is gum hygiene, because that's where the actinos are. So if you're not using fluoride, heaven forbid if you take fluoride out of the water, don't do that. We'll see an explosion of dental problems related to what's going on with toxins in the jaw. But the issue is that I have not done any research and have not seen any papers showing movement of actinos from sinus, and I still haven't seen much about actinos in sinus to begin with, but I haven't seen it going to the jaw itself. How does it say, is there going to be actinos in food that we eat? Well, of course there will be. So we're going to inoculating our jaw and our gum line with actinos every time we eat popcorn and whatever else is going on. For people who have real bad periodontal disease and seeing periodontists and getting deep cleaning and all that, is that getting rid of actinos? Absolutely. Absolutely. So if you use just a good reason, but this is not with a rinse of an antibiotic. It's not with a rinse of cholestyramine. It's with good gentle hygiene. It's getting rid of the habitat. The lesson to today's visit has been, you want to know what's going on in wet or damaged building? Establish what the habitat shows. This is disease of the habitat.
And you mentioned already the use of compounded lactobacillus nasal sprays. It seems to me like there could also be a place, and there are many products emerging in the market that are probiotic lozenges for the oral cavity. Any thoughts or concerns about that approach?
I have no data. It's a great question. I look forward to you answering it for me.
How important is considering a spouse or family members or pets in creating the right environment for the success of an actinobacteria-focused treatment protocol?
Well, I have been promoting for a while having spouse or loved ones get nasal culture and skin actino testing if the indicated patient is a spouse or a loved one. It's uncanny how often you will find actino skin positive in someone who's sick and actino skin positive in someone who's not sick. And if you wait with someone who's not sick, they do get sick. So it's just a matter of timing. You've got time to go after that, but you don't have time to postpone it forever. It's not a case where this is going to be a benign condition that you can live with forever and not worry about it.
So that leads me then into my next question, which is in the overall treatment of actinobacteria as a potentially causative trigger in CIRS, do patients reach a point where treatment is no longer necessary? Is this something that will require long-term management of the actinobacteria populations, similar to those that maybe still need to be careful about coming into a moldy building if they've had mold and mycotoxin triggered CIRS? And then extending on that, is actinobacteria in the P. acnes and CT realm, are those things that the goal is to eradicate, or is that even possible?
The goal is to control, not to eradicate. By pulling hair out to destroy, they live in the mouth. You're not going to get rid of them. They're there. They live in the gut. They're there. It's just a matter of controlling the balance, and you will see too much yeast, too little yeast, too much bacteria, too little bacteria, too much actino, too little actino. The true actino infections do occur, and there's a section in your textbook in medicine, and you'll find the sulfa drugs are used, and veterinarians will take care of actinos with a big lumpy, bumpy jaw that a cat's got from a fight. Cat bites will inoculate actinos under the skin. That's one reason they're so tricky. But specifically, we're looking at FAB, fungi, actino, and bacteria. We don't want it to eradicate, we want to control.
When we used to think of CIRS as more of a mold and mycotoxin illness, there was some conversation around treating, getting through your, I believe, 11 steps, and then step 12 was VIP, which then provided the person with more ability to be in an exposure and maybe not have the same type of reaction that they may have had before. Is there any connection between VIP and increased tolerance to future actinobacteria exposures?
It is a wonderful addition to the armamentarium. It will reduce toll receptor 2 levels. It'll fix the inflammatory cascade that's bothering people. VIP is going to be something that everyone's going to use if they've got an actino problem.
One of the things that was mentioned in one of your publications was that some actinobacteria promote more inflammation when the host is fed a high fat diet. We've also talked about the lipophilic nature of actinobacteria. Is there any value in specific dietary recommendations that could be supportive in actinobacteria triggered CIRS?
Yeah, I almost regret putting that sentence in the paper. I think I was padding references, quite frankly, but that had to do with the idea that a high-fat diet would feed Corynebacterium amiculatum. Remember, the amiculatum is the only one that doesn't have a mycolic acid. That's a human habitat. It pushes IL-23 a little bit, not very much. I think it's a wooden pearl myself.
So it sounds like there is not a specific dietary recommendation or necessity for change to support the actinobacteria reduction strategy.
Well, I think the seafood diet is an excellent choice as far as dietary means. You know what the seafood diet is? You seafood and you eat it.
Similar to your introduction on the history and background of actinobacteria, wondering if you can set the stage for our conversation around endotoxins.
Be glad to. The question is, what are endotoxins? Most people are asking that when the first time I started mentioning that. Gram-negative bacteria have a cell wall sandwiched between an inner cell membrane and an outer cell membrane. The outer cell membrane contains lipopolysaccharides made up of lipid A, core polysaccharide, and O antigen in the outer leaflet and phospholipids in the inner leaflet. So the endotoxin is the outer leaflet with a lipid A core, polysaccharide, and phospholipids restricted with the inner leaflet. But the gram-positives have no outer membrane, so teichoic acid and lipoids of gram-positive are absent. So the key issue is that this is the structure. I mean, one organism has got two cell membranes with a cell wall stuck in the middle. That just doesn't make sense. Why would that be there? We know that gram-negative rods are with LPS have a potent inflammatory agent involved in their structure. So maybe that's a defense mechanism. It's an asthma trigger. It's recognized by the innate immune system, activates toll receptor 4, toll receptor 2, recognition by CD14. And these expression of key molecules, we were focusing on the dose of exposure, co-exposures, and genetic susceptibility, are all involved with immune expression. So if we look at structure of lipid A, there's a variety of different lengths, different chemical composition. Polysaccharide side chain varies between strains of the same species. So you can't say an endotoxin from E. coli is the same in every E. coli. It's going to be different by the structure of the lipopolysaccharide. The full toxicity is based on the hexoacyl component of lipid A. And you don't need to know about pentacyl components because they don't have those in lipid A. Differences in phosphoryl moieties and estrogen-linked fatty acids are also determinants of toxicities. Bottom line, the diversity of the structure leads to differences in health effects. So what about characteristics associated with indoor endotoxins? The location within the home is key. The census division is key. Education is key. Presence of children is key. Presence of dogs, cockroaches, food debris, and smoking are all important. You had asked questions about endotoxins. All of those things have been studied in research and found to be increased incidence. Just dust on the floor is a reservoir for endotoxins. Another study family room dust, presence of dogs, marginal association with water damaged building, total fine dust, concrete floor in the family room, use of a cold mist vaporizer. There is one comparison of beta-glucans to endotoxins. Airborne particulates and dust were associated with inhalable endotoxins. Temperature and inhabitants, number of inhabitants were important. Dogs they found were inversely associated with beta-glucans. That didn't say that you should go out inoculating the home with beta-glucans to get rid of endotoxins, but it sounds like that author was after that. There have been a number of health exposure risk studies done, not really much with water damaged buildings. Remember, AW 0.90 is going to be the critical issue. Now, as far as endos and mycotoxins, there's a paper from 2011 with Taubel and Silyak. Michael Silyak, you should be reading his life literature. He says if you go into a wet building and you do an assay for mycotoxins, if you don't find 500 different mycotoxins, you haven't done your job right. 500. And he says there's a need for a sound risk assessment concerning the exposure to indoor microbial toxins at concentrations detectable in water damaged indoor environments. So he's saying there is a concentration problem and not just motility problem that actinos have. Walser was looking at this endotos being an undiagnosed problem. Lack of studies with valid dose response, diversity of methods for microbes, heterogeneity of health effects, insufficient exposure assessment. The fourth paper was measurement of airborne endotoxins vary from one lab to another, no standardization found. All he's mentioned is how do we know what we're talking about with endotoxins? We really don't. And when the academics have been looked at it, they haven't just been too much. Envirobiomics is the endotoxin assay. It's a limulus amoebocyte, lysate LAL. They now have replaced that with a kinetic chromogenic method as the most accurate, sensitive. So if you're going to get somebody doing an endotoxin assay, ask what method are you using? One thing, just for looking at mean endotoxins less than 100, the mean for endotoxins is 46.5. For endotoxins greater than 100, mean for endotoxins is 2560. And one of your questions about endotoxins, you asked about 100 or what. We know that over 100 endotoxin levels go nuts. Same thing along with actinos. If actinos are low, compared to high, the mean actinos is tripling. Same thing with hurts me too. So just remember that on all these different things, if you've got an ERMI of 7.86, that's too high. The associated endos with that number is 712.8, and actinos is 180. So a little bit of data from envirobiomics says that if you've got one marker of ERMI 7.86, the other two will be elevated as well. So endos are going to be with fungi is what that piece of information says. And lastly, if we look along this way at neuropont, Gini goes hand in hand with neuropont, and endotoxins have a marker for injury to cortical gray and nuclear atrophy greater than 3. And then also looking at the superior lateral ventricle. Here's where the endotoxin link, toll receptor 2, is coming in. And I'm afraid that if we don't find out more about endos early, we'll be trying to find it out with brain biopsies later. This is a significant problem, and it has my full attention. Not that that means it makes a difference, but it'll help me sleep better at nighttime knowing that I try to figure out how to fix degenerative neurologic disease from a skin rash.
So endotoxins, then, you shared with us, are cell walls from gram-negative bacteria. When we think about the endotoxins impacting the human, is it that the endotoxins are being released in our external environment from bacteria and that we're then inhaling these endotoxins?
Yes.
Is it that certain bacteria in the environment are releasing these endotoxins that we then inhale? And what are the types of bacteria that we're finding in the external environment that are the more prolific endotoxin producers?
Any organism, any gram-negative rod that's in AW of zero point 0.9 or greater will be releasing endotoxins. Doesn't matter whether it's an uncommon one or a common one. I hate to tell you that ivermectin works on endotoxins, but I'll just let that go.
And so, just to summarize, then, the endotoxins that are affecting people with CIRS are coming from the bacteria in the environment, producing endotoxin inhaled into the system, not that the bacteria in the environment are affecting the body.
Correct. When you inhale air with endotoxins, you will have endotoxins in the lung, or alveolar macrophages will ingest these organisms just like they do with fungi. That's the reason that you don't have whole fungi floating around the body very much. You can have infections, but if you have organisms putting endotoxins in alveolar macrophages, you will have inflammatory responses in the lung and into the bloodstream. The endotoxins don't stick around because they're lipopolysaccharide binding protein.
And when you say the endotoxins don't stick around, meaning we've inhaled them, they ultimately are in the body, but we still potentially need to remove them with things like cholestyramine and Welchol, or are you suggesting that the body will ultimately remove them even though they may be triggering CIRS?
Having seen numerous people who had endotoxin exposure, significant endotoxic exposure, sewage leaks and all that, 6 months or a year before, but no others since, still being sick, there is a fingerprint of an immune activation from endotoxins that will live on when the endotoxin is gone. And we don't know how long endotoxins are going to stay. You can't tell, maybe with a blood test, maybe some other way, but just for a 1 month of cholestyramine or Welchol for an endotoxin binder, then you quickly get to the immune phenomenon, which is where endotoxins live.
Talk to us then about where in a building we are likely to see these bacteria that are producing endotoxins. You mentioned sewage backups. Do we see these in drain pipes in bathrooms? Is it possible that it's coming from bacteria in soil underneath a home and moving itself then into the home through the foundation of the home itself? And are endotoxins ever associated with water intrusions that we think of from roof leaks and water intrusions?
The answer to your last question is yes. Endotoxins coming in from a big roof leak will have an AW greater than 0.9. When you have bacteria in your ceiling or in your soffit, or when your vent from your bathroom is venting water into the attic, you will have 0.9 up in the attic, and now your attic is a source of endotoxins. So it becomes, yes, dust will hold endotoxins. Yes, AW will hold toxins. Those are the main sources. But if you've got a sewage leak or a leaky seal of a toilet, or if you have an old-fashioned round toilet as opposed to the oval toilets they're using these days, you're going to have more trouble with endotoxins there. And so all these things you can't measure all of these things. You measure visual contrast sensitivity, you do floor dust sampling on a regular basis. If it's under 100, you're okay. If it's over 100, you're not.
You mentioned earlier that actinobacteria remediation could be a $50 endeavor. It sounds like endotoxin reduction or remediation could be more traditional remediation that could be much more expensive if, in fact, it was from some type of water intrusion, correct?
It is correct. The co-occurrence of endotoxins with fungi cannot be ignored. The co-occurrence of endotoxins and actino cannot be ignored. We have 15% of the genies that we've done have mixtures of endotoxins and actinotoxins.
And do we think there are some scenarios where the source bacteria producing the endotoxins are actually under the foundation of the home, and these endotoxins moving then into the building envelope, into the air that we're breathing, or is that not something that we need to be concerned about?
I think we need to worry more about moisture coming from the soil and not bacteria coming from the soil. Bacteria will come with air coming through a vent or some opening, and it'll colonize a wet, dusty concrete floor. But if you put a piece of swimming pool liner underneath your concrete pad, you'll stop water intrusion. That's the first step to helping endotoxin reduction. But the key issue is making sure that the basement is in the crawl space has been cleaned and sealed.
So not so much that the bacteria are coming from the soil, but that moisture is coming from the soil, which is then potentially leading to bacterial growth in the basement itself that then is an endotoxin producer.
Yes, if you've got a sump pump as well, if sump pump's got water in it, I don't know about P-traps. So your question's a good one. But the sump pump will always have gram-negative rods in it.
I know we touched on this briefly in our last conversation, but wondering if we think that over time there will be some consideration around endotoxins that are produced endogenously in the body from sinus infections, dental infections, gastrointestinal dysbiosis. And if that's unlikely, how is the body differentiating between an endotoxin that we inhale from our environment versus one that is produced internally?
We know that lipopolysaccharide binding protein is active every single day. So you can have a bowel movement and have endotoxin in your gut, into your blood, and then it's pulled out, bound by LBP, bound to a red cell, then endothelial cells. And that's one we know. We don't know is the time to remove endotoxins from LBP alone. We know that we use bile acid sequestrants to treat people with endotoxins. A lot of that is based on faith. And some people don't want to do it. They don't have faith. But the issue is that until we have the assay for lipopolysaccharide binding protein, we don't have the assay. Until we have that, we'll still be questioning how did the endotoxin get into the blood.
You mentioned that the endotoxins themselves are fairly readily removed from the body, but that there can still be an immune activation or immune process that's triggered. Could the endotoxins produced in the body be present long enough to trigger that same immune process, even if they are ultimately removed from the system?
Yes, and that's a big question. What do we do when someone is exposed to the bathroom flood in elementary school when they're in college? Could they still be ill for after 15 years of endotoxin effect? Well, if they're making IL-15 or toll receptor 2 or IL-15, then we've got questions to ask. It's the same thing with Parkinson's. We've got now the fingerprint for Parkinson's. We found it in a 4-year-old. Do we treat him to prevent Parkinson's at age 60? We don't know.
So am I understanding correctly that even though the endotoxins that could be produced endogenously themselves are likely addressed by the body fairly readily, that there is still some question around whether endogenously produced endotoxins could still trigger some immune activation that could be a contributor to CIRS?
We know with one-time exposure, with injection of endotoxin into Parkinson's ganglia area in brain in rats, that 6 months later, they've developed an immune response to a degenerative neurologic disease that doesn't clear on its own. A single exposure of a lab rat.
So I'm taking that as it is potentially possible that endogenously produced endotoxins could also have a similar immune activating impact.
Right, and that's one reason that this whole field of CIRS is so important now that we're headed towards the brain. It's like, what targets the brain? Well, biotoxins do. Is it all just beta amyloid, or is it something else? Are we looking at a vascular model of dementia? They're working on in Rockefeller University in New York. Sidney Strickland's group is looking at the vascular problems. Well, the vascular problems are coming from microglial cells activated by endotoxin.
So if these endotoxins can be readily removed with cholestyramine, with Welchol, with the body's own abilities, How do we then address the immune activation? How do we treat that ongoing immune dysregulation?
Well, VIP fixes it these days. Do we have enough people in the study? No. Is this FDA approved for this kind of stuff? No. Is this just idle speculation on Sunday afternoon? Maybe. But I still don't know that I've got the right answer what to do with a 4-year-old who's got a Parkinson's genomic fingerprint.
There are some labs now that test for lipopolysaccharide antibodies in the blood. Is there any value in looking at whether or not someone's immune system is reacting to lipopolysaccharides? And if so, does that correlate with Gini findings?
Well, if we had CD3D on these people, we would know a little bit better about antibody production. I have a feeling we're going to find the antibody production is some days yes, some days no. Memory cells are going to say you're going to be making antibodies all the time. We also know that that's subject to immune injury from other things. So CD3D can be made just fine, but then when it's not fine, then antibody production takes a hit. But we still don't even have a lipopolysaccharide binding protein assay.
If someone is dealing with CIRS and has not done a Gini, what are some of the other pieces of information that could potentially lead us to a hypothesis about their potential triggers? You mentioned earlier that there are patterns for endotoxin on NeuroQuant. Are there patterns for actinobacteria on a NeuroQuant? And do we
Yes.
see any variations in any of your original biotoxin markers, TGF beta 1, C4A, MMP9, anything unique in terms of the levels of any of those that lead you to say this is more likely one cause than another?
The interesting thing is that the protocol has stayed intact. People have had their opinions, yes or no, over the years, but it still works. If you follow the directions and don't get creative, then the life works. But the issues are still, we've got a pattern in NeuroQuant that we can use for Gini as well. We can find endotoxin patterns. We can find actino patterns. We now can find beta glucan patterns. But that doesn't tell us what's going to go on with Parkinson's or Alzheimer's. Yet, I think that we were looking at buildup of exposure over a long period of time of immune response that is renewed with each additional exposure. It's not necessarily every time you use the commode, but it could be for people who have LPS binding protein deficiency. And then how are we going to give LBP to people that don't have it?
Would you be more inclined these days to start with Gini or to start with NeuroQuant if you're attempting to determine potential causes? My understanding was that Gini can give us specific causation. I don't believe that I've heard the same is necessarily true about NeuroQuant, but which direction would you work in relative to Gini and NeuroQuant?
At the CIRS summit meeting in December 3rd, I presented the NeuroQuant data on specific fingerprints in there. So we've known for 2 months.
So would you only these days run a NeuroQuant after you've looked at a Gini to see what impact their specific causation might be having on the brain? Or is NeuroQuant still a commonly used tool early in the process?
I asked the question, how's your brain working? Guy says, perfect. I don't have a thing in the world wrong. I'm not going to order a NeuroQuant that day. Probably ask him next week, how your brain working? But if he says, my brain's not the same as what it was, boom, NeuroQuant. Boom, Genie.
And when we're thinking about the original biotoxin markers, TGF beta 1, C4A, we've generally said those were non-specific. There's this soup of mold mycotoxins, bacteria. There's so many different contributors now, actinobacteria, endotoxins, beta glucans. Are there any observed differences that could be more specific, or are those still non-specific markers?
Well, non-specific. Good question. I mean, we've broached that a couple of times in this interview. Still the same thing. TGF beta 1 will go up with inflammation, but it doesn't tell you what made the inflammation start.
We know that mold spores, mold fragments, mycotoxins can readily move through an indoor environment. You touched on the idea that actinobacteria can also be readily moving through an environment. Is the same also true of endotoxins? If we have any of these in our home, are they generally throughout the entire building, or do they ever stay isolated to the source?
They'll move. They're airborne primarily. That's one of the things that is going to be a problem. But endotoxins are very low molecular weight, so they don't fall out of the air very quickly. That's why you use a filter to take them out.
Many people are familiar with the idea of SPC, or small particulate cleaning, traditionally thinking in the mold and mycotoxin realm. You touched on essentially that concept with Fantastic for reducing actinobacteria. Is there also value in a small particulate clean in the endotoxin realm as well? And are we still primarily thinking of simple detergent, microfiber cloths, and potentially Fantastic or Windex if the issue is more actinobacteria?
Well, the latter is for actinos. As far as endos, I don't have data. I think Greg Weatherman does that will show what SPC does to endotoxins. I just don't know that.
I wanted to, as we're wrapping up, briefly touch on the idea of beta glucans. My understanding is that they can come from some fungal organisms, some yeast, some bacteria. So when we're talking about beta glucans and CIRS, what do we believe is creating beta glucans in the environment? Is it fungal? Is it bacteria? Is it both? And then is the impact through inhalation of beta glucans in the external environment?
I think it's both more fungi than anything else. And I'm sure there's beta glucans in yeast. To a certain extent, in gram-positives is where you'll find them in bacteria. But if you have inhaled beta glucans, you've activated the inflammatory pathway. The innate immune receptor is a different one. Dectin-1 and Dectin-2 are different sources. Same theme, different players.
And building on the beta glucan conversation, there are many supplements people take with beta glucans to support their immune system. Should we be concerned that those could potentially be additional contributors to CIRS?
There will be some identifying labels on beta glucans that are safe. If they're B-D, parenthesis 1, arrow 3, and parenthesis beta glucan, that's the baddie. That's the one that turns on Dectin pathway. But 1,6, as far as I know, are not harmful. And if they're BD or is a problem, it's not BD. It's not really the same problem with people with cyanobacteria. People were using blue-green algae supplements, and they were harvesting the supplements from Lake Klamath or Klamath Lake in California that's full of microcystis. And it's like, don't do that. So I would not be using beta glucans, because the manufacturer can put anything he wants on that bottle.
What do you see on the horizon that could be a potential game changer for those dealing with CIRS and help to make recovering health more of a reality than it has been for many?
We have talked about maybe 15 different research pathways that had merit today. Any one of those could be the missing link. I personally think the answer is in the brain. It's in neurologic disease and degenerative disease. Until that one's straightened away, and just look at all the time and money people have tried to treat Alzheimer's with the same question you asked. And they spend an awful lot of time, an awful lot of money, and don't have any answers. I think if we've got immune system abnormalities, and there may be proteins. There's a group that's been working with Jimmy Ryan on the biobank to be doing a whole of people known CIRS, looking at a whole series of proteins that could be important. I don't know which ones they're working on. I have no idea if they're even working on it. But the point is that smart people are looking at CIRS differently than ever did before. And, I'm going to say brain, but someone else may say protein.
My last question is always the same for every guest, and that is, what are some of the key things you do on a daily basis in support of your own health? We answered that not long ago. So maybe what is the most exciting thing that you're doing today to support your own health?
You found the right woman and married her.
That's a good answer. I don't know that I've had that answer in 210 previous interviews. So
You need to meet Cheryl. You see why I talk that way.
amazing, amazing. Dr. Shoemaker, wow, this was a brain exercise for sure in trying to keep up with you. I learned a tremendous amount from our conversation. I believe this is the year of the 20th anniversary of the book Mold Warriors, if I'm
Yes,
remembering correctly.
you
And
are.
so, congratulations on having started this conversation many years ago. And I just want to thank you for continuing to dig deep in this realm and to try to better understand the things that are contributing to many chronic health challenges and to continue to explore potential tools and solutions that can really help to improve the quality of our lives. So thank you so much, Dr. Shoemaker.
Thank you for those kind words. I appreciate it. Have a real good afternoon.
To learn more about today's guest, visit survivingmold.com. That's survivingmold.com. Survivingmold.com. Thanks so much for listening to today's episode. If you're enjoying the podcast, please leave a positive rating or review, as doing so will help the show reach a broader audience. To support the show, visit betterhealthguy.com/donate. To get my newsletter, visit betterhealthguy.com/newsletters. To follow me on Facebook, Instagram, X, or TikTok, you can find me there as Better Health Guy. This and other episodes can be found on Apple Podcasts, Spotify, Amazon Music, YouTube, and Odyssey.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.